So we're going to go through basically just some of the prevalence of inflammatory bowel disease in the US. We're going to understand, for those who don't know yet, maybe a little bit more about how hyperbaric works and why. Very surface understanding, but I just want to make sure that everybody's on the same page. And then we're going to talk about some of the mechanisms behind healing wounds, just general wound care as it comes to hyperbaric, because that's one of the most well understood and probably one of the most well studied topics in hyperbaric, and how similar it actually is, the pathophysiology between traditional non-healing wounds and the wounds of inflammatory bowel disease. And so for sure there's a huge amount of overlap between those two. And if we have time, which we probably won't, maybe a few case studies so from our clinic. So real quick, I mean, these are just to show, I mean, there's obviously an enormous increase in inflammatory bowel disease in the US since the 1960s, 1970s. But if you look at a graph like that, which is just looking at, you know, different countries over time as it relates to ulcerative colitis and Crohn's disease, I mean, the amount of increase is enormous. But we could put a slide for the majority of autoimmune diseases in the US, and those, the graphs would look pretty similar. You know, there's just an overwhelming increase in toxicity and inflammation, and obviously inflammatory diseases like autoimmune diseases in the US. And, you know, I mean, I think we're covering a lot of those bases here this weekend in the various lectures. So roughly 1.3 million suffer from inflammatory bowel disease. Obviously that's increased a lot over the last, like I said, probably 30 or 40 years, but really in the last, I'd say maybe 10 or 15 especially. About 25 to 30% of those are people under 20 years old. And although right now adults make up a larger percentage of that number, children are growing in terms of inflammatory bowel disease. Those numbers are growing every year. So, you know, just something to point out, and I think we all know this in this room, but I want to say it out loud, because it shows up in the literature, but not as much as I think that it should. But it says, you know, while these numbers are increasing and have been for the last, you know, 30, 40, 50 years, you know, those increases are clearly larger than what can be explained by genetic factors alone. You know, our genes are mutating. We certainly are having issues here. We have SNPs and other issues as it relates to our genetic code. But at the same time, our genes are not changing at the same rate that we see the increases in inflammatory bowel disease or other autoimmune diseases. And so therefore, we can't blame a curve, you know, of such high increase to something that really hasn't changed anywhere near as much. And, you know, we need to understand that there's so many other factors related to autoimmunity and immune system disorders than simply just the genetic explanation. You know, it says here that the traditional main goal of care for inflammatory bowel disease, and again, this is also true for the majority of autoimmune diseases, is really just symptom control. Can we suppress inflammation? Can we reduce symptoms enough to allow people to have as close to what we would consider a normal quality of life? And can we either prevent surgery or at least delay surgery as long as we can? I mean, that's really the extent to the goal in traditional medicine as it relates to so many autoimmune diseases. You know, a lot of these kids are ending up on anti-inflammatories. Biologics are increasing in a great amount over the last few years, especially. Also antibiotics. And again, we're really just treating symptoms. We're not actually getting to the actual causes behind any of these diseases when we do it like that. And just an interesting comment was, you know, that we need to also make sure that we're providing adequate nutritional support to maintain normal growth and to minimize, not just to minimize the symptoms and not just to minimize the, you know, the experience that patient's having, but to also increase quality of life. But we need to start looking for other therapies, different treatments that are actually going to maybe help either get to things a little sooner in these patients' lives, or maybe start to steer them away from inflammation and autoimmunity earlier on, or certainly at least look at exactly how these mechanisms are at work in these patients' bodies, and are there things that we could do to not only prevent the symptoms, but actually encourage healing and repair of the tissue. And that's really what we're looking to do. And so while not all the pathways of inflammatory bowel disease are well documented, many of them are, there's typically some degree of acute inflammation, followed by loss of blood flow because of inflammation and damage to the microcirculation. We get an inflammatory release of pro-inflammatory cytokines, which leads to a further breakdown of tissue, which we're going to cover in a little bit more detail in a few minutes. Obviously, inflammatory bowel disease, the rates of SIBO are higher in those with inflammatory bowel disease than without. Not that that's causal, it's more of a correlation than anything else, but the idea that other microbiotic issues, the cultures of the microbiome in these inflammatory bowel disease patients are clearly very different and much higher levels of pathogens than in normal samples. Some of the characteristics, obviously, we have an increase in inflammatory cytokines. We have local hypoxia specifically around the damaged tissue, which leads to a level of chronic anemia in a lot of these cases, microbiome changes and bacterial imbalances. We have mucosal scar tissue development and a breakdown of the epithelial tissue. This is a slide I use a lot just to describe for people to better understand the interconnectedness of chronic illness and chronic inflammation. And it's just to show, I mean, you could sort of insert yourself at any point along this cycle and it would still remain true. But in general, we're gonna have some type of tissue damage along the way, and that tissue damage leads to a breakdown of the microcirculation. As you have a breakdown of the microcirculation, you just start having a decrease in oxygenation. There's just less blood flow flowing to the tissue. As you get a reduced blood flow, you're no longer able to get the nourishment that those cells need to function properly, and you're not able to get the inflammatory chemicals away from the area as quickly as you need to, and as a result, you start to develop inflammation, period. It depends where that is. So that could be GI inflammation, that could be neuroinflammation, that could be musculoskeletal inflammation. It just depends where this issue is taking place. As a result of this decreased oxygenation, this decreased ability to get rid of inflammation, you start to get metabolic dysregulation, mitochondrial issues in terms of ATP production, in terms of clearing all those chemicals out. So then we start to get upregulation of the immune system, increase in oxidative stress and reactive oxygen species, and then eventually you're going to start to get nuclear damage and DNA damage, and the cycle continues. So in terms of inflammatory bowel clinical management, if we had a way to intervene a little bit more meaningfully, and we could do something that could control inflammation, or at least start that process of reducing inflammation. If we could increase the oxygenation to the tissue, because one of the characteristics was hypoxia at the wound site. If we can improve the nutrition, I don't mean just nutrition in terms of what we're eating, although that's part of it. I also just mean nourishment to the cell. If we can deliver the nutrients to the cell properly and balance the microbiome, then we would have a meaningful therapy for a lot of these patients. And the rest of this talk is really to say hyperbaric plays a role in all four of those places. And so this one therapy has a very large capacity to improve patient care on these cases. So just a real quick summary on how hyperbaric works for those that may not be as familiar. We're looking at how do we increase oxygenation to the tissue. And so in one way we could talk about it and say, everybody knows what a pulse oximeter is, and then we're looking at basically how much oxygen are our red blood cells able to carry and what percentage of oxygenation are we at, which is clinically important. However, when we're talking about hyperbaric, we're really going beyond that, because we're using gas laws, which we'll cover in a second, to hyper-oxygenate well beyond what the red blood cells are actually able to carry. And as a result, we're able to go beyond the 100% saturation that we talk about when we talk about SpO2. Another analogy I'll use just to kind of bring home an idea to put it in people's heads. But I look at oxygen as a nutrient. It's something that our cells require for proper function. And while we don't eat it, it is part of the nutrition to the cell, and it's a critical piece. We have the ability to go days or weeks or even months without actually eating food. We can go days without water, but we can only go a few minutes without breathing. And so it's interesting because it's a nutrient, it's critical for our everyday function, but we have almost no storage for them the way we do for other nutrients. And so oxygen becomes this critical piece. And while we have enough in general for healthy, we have enough for our normal function, we don't always have enough for an additional amount for recovery and healing in certain cases. And so I'll use a vitamin analogy. Vitamin C might be a critical nutrient in our body. And if you don't have enough, you have a deficiency in vitamin C, we have a name for that, right? It's called scurvy. So we try to get as much vitamin C as we can, or not as much as we can, but at least the minimum amount so we don't get scurvy. But a lot of us would then take it a step further and say, I don't want just the minimum amount, I want like the optimum amount that actually gives me all the vitamin C that I need for all the functions that it does in our body. And then beyond that, you might say, well, gee, I have a cold or a flu, some sort of issue. I want a mega dose vitamin C. I want way more for a short period, way more vitamin C, because I need to mega dose that to make sure I have enough to even do all my normal functions and now fight this infection. So I would say the same is true about oxygen. If you don't get enough oxygen, we call that hypoxia. Beyond that, you want to make sure you're getting the optimum range of oxygen. So for us, that's, let's say, 98 to 99% saturation in our red blood cells. But just because we're getting that doesn't mean we're always getting as much oxygen as we need to really get to the tissue, especially for a healing issue or a chronic inflammatory disease like inflammatory bowel. So we might want to hyper oxygenate, mega dose oxygen for some period of time to create that reservoir that we don't have otherwise, so that we have oxygen enough to go to these other areas of damage and heal. And that's exactly what Hyperbaric's able to do. Just a quick summary on gas laws. So just Henry's law and Boyle's law, very, very simple explanation. But Boyle's law is basically just saying, as you exert pressure on a gas, you can take a gas that takes up a certain amount of volume, increase the pressure, and smush that gas into a smaller volume. And then because of Henry's law, you could dissolve that gas into a liquid. And so a can of seltzer or a bottle of seltzer is probably the easiest way to explain that. You're taking a gas, in this case it's carbon dioxide, not oxygen, and you're using water, let's say in this case, in our bodies we'd be using our plasma, but you're taking gas, carbon dioxide, and you're creating pressure on it, and now you're dissolving that gas into the liquid. If you looked at a bottle of seltzer before you open it, you might not even see that there's bubbles in there. It just looks like water until you open it, and all of a sudden you get this release of bubbles. And so in a lot of ways, that's how hyperbaric works, but we're using oxygen in those cases, and the liquid that we're dissolving that oxygen in is our plasma. And that's how we're able to hyperoxygenate our bodies. There's a lot of different ways that hyperbaric influences our body. These are 4 of the most important, I think. But one is that it increases free-floating oxygen. So again, if we have 98% oxygen in our body, or 98% saturation, we can go beyond that 98 or 100% to create a free-floating oxygen that's actually able to get to the tissues that we need it to get to. And because of that dissolved oxygen, because it's not bound to red blood cells, it can get to places that oxygen bound to red blood cells can't get to because of damage. When there's damage to the capillary system, you can't get red blood cells always to the areas that we need to get it to, and as a result, that tissue stays hypoxic. If you could dissolve oxygen into the plasma is able to get where the red blood cells can't, and now all of a sudden you can deliver oxygen to a place that was damaged that's now getting the oxygen it needs to heal. More importantly, once that happens, it has an angiogenic effect. So if we could start to rebuild the microcirculation, those capillary beds, so that they could start oxygenating themselves on a regular basis, even beyond the therapy, now that's going to be a successful treatment, especially when you're looking at wound care. So this angiogenic effect is critical, I think, especially in inflammatory bowel disease. And the last one is this dissipation, the seltzer. So the idea is here that you're pouring the seltzer in a glass, and when you do, it's very bubbly. And as you let it sit there on the table, those bubbles just start to come out of solution, and the liquid just, the gas in the liquid just balances out until it's just water again. And so that's also what happens when you get out of a hyperbaric chamber. The oxygen immediately, because there's no more pressure to hold it in to solution, that oxygen starts coming out of solution. But it's not like it just comes out of solution and is inert. It's actually interacting with our cells as it's coming out of solution. As a result, the distance, so there's a distance that oxygen is able to leave a capillary to affect tissue. The distance that oxygen is able to move outside of a hyperbaric chamber once it's been dissolved in solution is 4 times higher than it normally is under normal physiologic circumstances. So this increases the distance oxygen can travel, which increases the distance of the tissue that can be affected by the hyperbaric exposure. So there's a lot of detail in a lot of these slides, and you have them, so I'm not going to really cover it in as much detail as what's here, but the idea here is just to say there's certain pathophysiology of wounds, and these are very well documented, and it includes things like, we know that there's an inflammatory cascade of cytokines, we know that there's typically, and because of a lot of things, but let's say specifically because of the hypoxia, it allows anaerobes, which are typically, that love these low oxygen environments, it allows these anaerobes to thrive in the tissue. So it's really, you get these tough bacterial infections that are hard to handle in these wounds. Then these bacteria have a tendency to develop these biofilms to protect themselves, so that our medications and traditional treatment are a little less effective than they should be. The local hypoxia continues to impede the ability to get nourishment to the cells and clear that inflammation away. So these wounds are just really tough to heal, and they're not getting nourished, you're not clearing the inflammation, and it's a beautiful breeding ground for these pathogens to just live and continue to destroy the tissue. So, and we know, we typically, in traditional hyperbaric use, we use hyperbaric, it's one of the 14 indications is wound care. And we know that hyperbaric has this amazing capacity to shift all of that physiology. How does it do it? It starts to reduce and balance those cytokines. Back to the same slide. It reduces and balances those cytokines. It actually acts as a natural antibiotic because most of these pathogens are anaerobes. They can't tolerate these high oxygen environments. So these high oxygen environments start to shift the bacteria away from being able to have such a nice place to live. It actually helps to break down those biofilms, which, if nothing else, will allow more traditional antibiotic use to become more effective. Local hypoxia, obviously hyperbaric immediately changes local hypoxia because it's delivering oxygen, especially free-floating oxygen, right to the tissue. And as it rebuilds the microcirculation, you're actually going to continue to deliver the oxygen that it needs, as well as start to carry away a lot of the inflammation that tends to build up in these wounds. And so, when we compare that, again, I'm skipping through because a lot of this is wonderful, but you have copies of it. When you look at this and you compare a lot of the wound care, traditional wound care issues to inflammatory bowel disease, these are internal, non-healing wounds. These are very similar cell type from skin to our intestines, and there are these non-healing ulcerative wounds. And so the pathophysiology between a typical wound and an internal wound is very similar. And so as we understand that, it just makes sense to say that if hyperbaric works to help these outside the body non-healing wounds, it has a similar effect on these internal non-healing wounds from inflammatory bowel disease. Again, the summary of what it's doing is it's increasing the angiogenesis. It improves all these cell-derived growth factors, brain-derived growth factor, platelet-derived growth factor, collagen synthesis, VEGF. So it's really improving a lot of the cell signaling that our cells require for tissue repair and healing, down-regulating inflammation, increasing ATP production, and has that really strong antibacterial quality. And then when we talk about even just microbiome in general, we could say that the majority of the probiotic that live in and on us are either aerobic or at least very oxygen tolerant. And so when our bodies have high levels of pathogenic anaerobes, being exposed to a hyperbaric environment for some period of time allows us to start to shift that microbiome away from some of those pathogens, makes it really uncomfortable for a lot of those pathogens to thrive, while also improving the environment for most of our probiotics to live happily inside of our intestines. That's all really interesting and fabulous, but again, you have copies of all of it. So I just want to take the last few minutes just to give you maybe a few cases. These are just from our clinic, but just want to share a few success stories. They're not always success stories, you guys know that, but I like to share success stories because they're fun and it gives us hope for the future. So here was a 18-year-old male. He was home from a winter break for college, ulcerative colitis, active fistula, anal fissure. He was on Humira, corticosteroids. He was in the middle of a flare. We have a local internal medicine doc who's pretty open-minded. So we become friends over time, and so he sent this guy over to us for treatment. But basically, active disease, 10 to 14 bowel movements daily, blood in his stool, moderate cramping. What they wanted to do, his GI doc, a partial colon resection over the summer, high-dose steroids to control the symptoms until then. So he was basically on winter break. They were going to do a full semester of high-dose steroids to see if they can control it, and then they were going to do the surgery over that summer. What we did was 20 sessions at 1.5 atmospheres, 100% oxygen, 90-minute sessions, 6 days a week. Outcome, patient had a decrease in frequency in blood in his stool. He went back to school having only 1 to 2 bowel movements daily. Blood was present less than half of the time. He was off the steroids. The fistula started healing but was still present, and he no longer had cramping in his gut. By the end of the semester, he was still doing better, but the symptoms were starting to come back. He thinks, finals obviously was a trigger for him from a stress standpoint. So they decided to actually delay the surgery that they were going to go do for that summer, and they wanted to do some more sessions. So we did a second protocol. We did 40 more hours over that summer, 60 minutes per session, 5 sessions a week. and basically had full healing of the fistula and the fissure over the summer. He was still on Humira, but symptomatic, and was for the past 18 months. This was a year ago, and he's still doing actually fabulous. So, and we haven't been treating him actively in hyperbaric since then. Another one, 24-year-old female, living at home, commuting to New York City for work, Crohn's and colitis, had a partial colectomy 2 years prior to us meeting. She was on Entyvio, methotrexate, active disease, having serious symptoms, cramping, blood in the stools, lots of urgency and frequency, and high-dose steroids for 6 weeks was what they wanted to do to control her flare. Her issue was that she could barely make it to work. She was always nervous that driving into the city, she was going to have an accident in the car, so she obviously had a lot of stress around that. So 30 to 40 sessions, 1.5 atmospheres, 100% oxygen, 60 minutes, 5 sessions per, 60 minutes per session, 5 sessions per week. She ended up not doing the steroids at all. She just chose to do hyperbaric. By session 10, she was only having 1 bowel movement a day. By session 15, she had no more blood in her stool or cramping. And 6 weeks in, she was completely asymptomatic. She's also, that was a while ago, that was 2016. But she does pretty well. Still comes in for maintenance periodically. Last one I'll talk about is a 10-year-old boy, Crohn's disease, corticosteroids, biologics, biologic resistance. So they had him on Remicade for a bit, Entyvio for a bit, Humira for a bit, didn't tolerate them, and couldn't stay on them. So also active disease, extremely gassy, abdominal pain, cramping, 5 to 8 bowel movements daily, anal fissure, blood in the stool, losing weight. They were really worried about his ability to thrive at the time. They wanted to do a partial colectomy. We did 20 sessions, again, 1.5 atmospheres, 100% oxygen. Week 1, no longer had blood in the stool. Week 2, bowel movement frequency decreased, cramping stopped. Week 4, noticeable healing of the anal fissure. We decided to do 20 more sessions after that. By the end of 40 sessions, fissure was totally healed. Patient was off steroids and completely asymptomatic. And it's a lot different. These kids, obviously, kids in the right environment, kids could heal so quickly. So, that's one of those stories that was a really remarkable one that happened so fast. A lot of these anal fissures and fistulas, while we see tremendous healing, they take a lot longer than that we notice in our clinic. Anyway, that is all I have for you today. So I hope you enjoy your lunch, and we will see you later. If you have any questions about any of this, feel free to ask me questions along the weekend. Thanks a lot.